This presentation will be about rehabilitation in the older adult. It's brought to you by the Dakota Geriatrics Program, which is funded by HRSA. The goals for this presentation include understanding a framework for helping people be more capable and independent. It's also looking at options for rehabilitation, including the setting for rehab. We want to talk about assistive devices and some environmental modifications that can enhance independence in the community. Finally, we will give some specific examples of stroke and orthopedic rehab. If we look at the framework for rehabilitation, the World Health Organization has an excellent construction here, where they divide rehabilitation into a functional consideration and addressing the disability. On the other hand, considering simultaneously the contextual factors, such as what is the environment and what are the psychosocial elements, such as motivation. If we focus on just the function, there might be some gains in strength and mobility, but if we don't think about the contextual framework, there could be potential offsets that prevent rehabilitation. Specific examples might include a family that does everything for the person under rehab, or that there may not be enough attention paid to alteration in the physical environment. The sites of rehab care may make a difference. Hospital-based care involves an interprofessional team. The skilled nursing facility is the more generic site for rehabilitation. Both of these are funded by Medicare A as a benefit. Clinic-based orders for both outpatient rehab and for home health can be generated with a multi-team approach. Recent practice guidelines, such as those from the APTA, now support telerehabilitation and hybrid care models. These have comparable outcomes and patient satisfaction to traditional in-person therapy for musculoskeletal and neurological conditions, particularly when paired with wearable activity trackers and remote clinician interaction. The site of rehab may make a difference, particularly in cerebral vascular accidents. Stroke rehabs are best in an inpatient setting. The literature and medical evidence are not as strong for hip fracture being conducted at one particular place. Both the inpatient and skilled nursing facility could be fairly similar in their outcomes, with the exception of the highly medically complex patient who may benefit from inpatient settings. Take a look at the interprofessional team. The physical therapist we consider as the individual that helps bring back strength, particularly in the lower extremities for transfers, gait, and mobility to gain additional independence, or to use an assistive device that will help in mobility. The occupational therapist, on the other hand, tends to be the individual that addresses deficits in ADL and IADLs as well as issues with cognition and vision, generally the fine motor skills, and then the rest of the team members are listed here with their particular focus. Clinicians are increasingly using wearable sensors, such as accelerometers and EMG, combined with AI to monitor patients' mobility and balance continuously. We have other members of the interprofessional team, such as the nurses, who actually execute the plan for ADL and self-care skills. The CNAs, or certified nurse assistants, assist the nurses in that process. We have speech therapists, and then finally the team is overseen by the primary care provider, whether that be a physician, nurse practitioner, or a physician's assistant. Wearable tools enable objective data on gait and movement both in clinic and at home, facilitating remote monitoring and personalized therapy adjustments. We need to really think about prevention as we enter into the rehab process. Avoidance of iatrogenic diseases, such as nosocomial infections or medication errors. Falls are prevalent in rehab settings, and that's because people are deconditioned. Pressure ulcers are potentially avoidable, although 20% of pressure ulcers may not be avoidable. There's a variety of reasons that people get pressure ulcers, and as can be seen here, the sacral ulcer is really difficult to heal. Social isolation and loneliness can be a big problem. It's one of those mitigating factors in preventing people from gaining full functional independence, as well as issues related to urinary and bowel incontinence. Avoid aspiration, particularly in those individuals that are later on in their years or have recovered from a stroke. Emerging research highlights ethical and equity challenges in delivering telerehabilitation to older adults. Factors like digital literacy, access, privacy, and inclusivity must be addressed to ensure fair and effective care delivery. In terms of stroke rehab, a third of the individuals have very severe deficits. Generally, these might range from hemiplegia, if your body is paralyzed, dysphagia, aphasia, visual problems, and cognitive impairments. The trajectory of recovery is slowed. The less potential for recovery, the more of those problems that you have as a result of stroke. There's additional risk factors for post-stroke, such as spasticity in the muscles, which can be painful and cause contractions. They can also experience pressure ulcers, and then finally, seizures, which older adults with memory disorders, particularly Alzheimer's, can also develop de novo seizures. Here's our first polling question to test your knowledge. What percentage of stroke patients typically experience severe deficits, such as hemiplegia, dysphagia, or cognitive impairments? A. 10%. B. 20%. C. 33%. Or D. 50%. The correct answer is C. 33%. The rehab goals for stroke are two, of course. Try to maximize functional independence in the activities of daily living. We want to consider the psychosocial elements about coping and about promoting adaptation. We also want to prevent recurrent stroke, and then overall, we want to assist the individual with re-entry into the community setting as best as possible. The stroke rehab trajectories can be viewed here in a general context. The first month is where most of the gains are made in post-stroke recovery. There's about a 3-month window overall, for the vast majority, 90%, of the stroke recovery. Thereafter, there's small incremental changes, and then you have the whole issue of setting here. As you can see in the graph, normal age changes and deconditioning may occur, since we lose 1% of muscle mass per year after the age of 60. It might be good to use the NIH Stroke Severity Scale to help the team understand both the likelihood of recovery and the extent of interventions needed. The earlier that the interventions are implemented, the higher the likelihood of a return to home. There's some specific techniques in stroke rehab that can be considered. One is to restrict or constrain the good limb. If you have hemiparesis, it forces the individual to use the so-called bad limb or the affected limb. You can use, as seen in the picture, a harness treadmill to help the person enhance their lower extremity movement. Mirror therapy is something where you use a mirror to look at the good side while practicing with your bad side. You can also use mirror therapy in amputation rehabilitation. There's a variety of other things, such as magnetic therapy for dysphagia, electrical stimulation, and a variety of other techniques, which still have yet to be fully proven beneficial. AI-driven tools are increasingly used, such as machine learning for motor impairment classification, robotics, and brain-computer interfaces. A 2024 review identified 4 main AI domains: impairment assessment, assisted intervention, outcome prediction or imaging, and neuroscience-informed therapy. AI algorithms, from supervised learning and deep neural networks to brain-computer interfaces, are gaining traction for real-time upper limb rehabilitation, using sensors like INUs and advanced pattern recognition to personalize therapy. In terms of the orthopedic realm, hip fractures are the bane of the older adult. There's a 5% high mortality during hospitalization, and a quarter of the people will die within 1 year. Early weight bearing after hip repair improves the outcome. The more intense the rehab, the better the outcomes. The geriatric collaboration with the orthopedist is a geriortho unit. It has improved outcomes and patient satisfaction, so that's a fairly new model of medical care. The integration of robotic exoskeletons in rehab, originally developed for paralysis, now shows promise for geriatric patients. Lighter, adaptive suits are emerging that help support gait and transfers in hip fracture rehab. For our second polling question today, we want to know: what is the approximate one-year mortality rate for older adults following a hip fracture? A. 5%. B. 15%. C. 25%. Or D. 35%. The correct answer is C. 25%. For orthopedic rehab, we need to consider deep vein thrombosis prophylaxis. Use an oxyparin or its equivalent for at least 14 days after a procedure. Like stroke, early mobilization is critical, as is addressing pain management. Individuals with a hip arthroplasty or a new hip, if they're over the age of 70 and if they have 2 chronic conditions or more, would benefit most from an inpatient setting for rehab. Adaptive equipment is important to consider. Examples are a raised toilet seat, the shower chair or bench, as well as a bedside commode for the person receiving rehab. There are some specific considerations about amputees. They tend to have a high mortality, particularly those with diabetes and vascular compromise. It's important that any type of rehabilitation have some prehab or prehabilitation for preservation. An amputee with a below-the-knee amputation, it takes more strength and energy to move around. If you have an above-the-knee amputation, phantom pain is really highly prevalent. We can use mirror therapy to reduce that. There's some medications that are partially successful in reducing, if not eliminating, phantom pain. The Chronic Disease Rehab Program, or Pulmonary or Cardiovascular Rehab, has the underlying principle of muscle strength training or resistance training increasing the mitochondrial density, and that improves oxygen uptake and utilization, thus reducing fatigue and weakness. If the individual has problems ambulating, or if they're wheelchair-bound, that upper extremity exercise is equivalent to lower extremity exercise for generalized benefit and endurance. We need to consider mobility devices. The straight cane typically is used in osteoarthritis and/or neuropathies. There's a variety of other assistive devices. Canes should always be used on the opposite side of the affected limb for osteoarthritis. The top of the cane should come to wrist level with the arms dropped at the side of the patient. Power chairs and scooters can really accelerate deconditioning, and they're to be avoided as much as possible. Not surprisingly, CMS doesn't pay for these, unless they meet a variety of criteria. They could be invaluable for end-stage conditions, such as heart failure and COPD, but otherwise in early stages of chronic conditions, not so much. The power chairs or scooters might be good for bilateral arm weakness, such as multiple sclerosis or Lou Gehrig's disease. Lightweight wearable robotic devices, known as exosuits, are being tested with older adults. While early trials show positive acceptance, widespread use will depend on cost, usability, and clinician support. Now let's take a look at today's case study. Patient profile: Mrs. Elena Rodriguez, an 82-year-old widow living independently in an urban apartment, suffered an ischemic stroke affecting her right hemisphere, leading to left-sided hemiparesis, mild aphasia, and balance issues. She has a history of hypertension and type 2 diabetes, common risk factors in older adults. Initial assessment and goals: upon admission to an inpatient rehab facility, Mrs. Rodriguez scored 12 on the NIA stroke scale, indicating moderate severity. Goals aligned with WHO's ICF framework: restore strength or mobility, gains, mitigate environmental barriers, offsets, and incorporate contextual factors like motivation through family counseling. The team, comprising PT for gait training, OT for ADLs, speech therapy for aphasia, nursing for continence management, and a PCP overseeing, aimed for discharge to home within 30 days, preventing complications like pressure ulcers or social isolation. The rehab team's composition mirrored best practices. Physical therapist focused on lower extremity strength for transfers and gait, incorporating harness treadmill training and early weight-bearing exercises. Sessions were twice daily, emphasizing balance to prevent falls, a key iatrogenic risk in deconditioned older adults. Occupational therapist addressed ADLs, dressing and bathing, and IADLs, cooking, using constraint-induced movement therapy to force use of the affected side. Fine motor skills and vision were targeted with adaptive tools like reachers. Speech-language pathologist managed aphasia and dysphagia through exercises and transcranial magnetic stimulation trials, aiming for a 3-month cognitive recovery window. Nursing and CNAs executed daily self-care plans, monitored for pressure ulcers using Braden scale assessments, and addressed continence issues with scheduled toileting. Primary care provider oversaw medical management, including secondary stroke prevention, aspirin, statins, and pain control to avoid barriers to participation. Preventive strategies were integral: DVT prophylaxis with enoxaparin for 14 days, fall prevention protocols, bed alarms, and screening for social isolation via the UCLA Loneliness Scale. Emerging technologies enhanced care. Wearable accelerometers and EMG sensors provided real-time data on mobility, integrated with AI algorithms for personalized adjustments. This aligned with 2024 reviews on AI in stroke rehab, which highlight domains like impairment assessment and outcome prediction using machine learning. Interventions and progress therapy began with constraint-induced movement to encourage use of the affected limb, mirror therapy for hemiparesis, and harness treadmill sessions for balance. Wearable sensors tracked daily activity, allowing AI-driven adjustments via remote clinician input. Hybrid tel-rehab post-discharge included virtual sessions twice weekly, supplemented by home modifications, grab bars, and raised toilet seat. Pain management and DVT prophylaxis were prioritized. By week 3, she achieved independent transfers and partial meal prep, with cognitive recovery noted within the 3-month window. Long-term considerations to prevent recurrent stroke, medications, and lifestyle education were provided. Community re-entry involved scooter evaluation, meeting CNS criteria due to bilateral weakness risks, though emphasis was on avoiding deconditioning. This case illustrates that while 33% of stroke patients face severe deficits, early team-based care can yield smaller but meaningful gains up to 12 months, with emerging tech like robotics showing promise for personalized outcomes. After 4 weeks inpatient, Mrs. Rodriguez transitioned to hybrid tele-rehabilitation per APTA guidelines, combining in-clinic visits with remote sessions via a tablet app. Home health aides installed assistive devices, a raised toilet seat, shower bench, bedside commode, and grab bars. A straight cane fitted to wrist height, used on the unaffected side, aided mobility, while family education reduced over-assistance, fostering independence. Virtual reality training improved strength, though functional gains plateaued after the initial 30-day milestone, with smaller improvements up to 6 months. Outcomes were positive but tempered by age. She achieved 70% independence in ADLs per functional independence measure, returned home with part-time caregiver support, and resumed modified community activities. No recurrent stroke or major complications occurred, though mild spasticity required ongoing Botox considerations. Mortality risk was mitigated, contrasting with the 25% one-year rate in similar hip fracture cases, not applicable here, but illustrative of ortho parallels. Phantom-like sensations were absent, but if present, mirror therapy would have been employed. In summary, rehabilitation should always be sooner rather than later. For optimal outcomes, it should be team-based. Address both the function and the contextual factors simultaneously so that you can motivate the individual. bring their social support system to help influence positively their adaptation and advancement towards independence. Strength training through resistance or weights can help build the muscle mitochondrial load, and that improves endurance and reduces fatigue. Always be mindful of pain as a barrier to recovery, particularly in the aphasic or cognitively impaired patient, who may not be able to express themselves and may have visual expressions of pain as opposed to verbal. Finally, always be an advocate for fall and stroke prevention. We appreciate your attention.